Good afternoon. Mental health is something very familiar to people with chronic illness like me. So this is very close to my heart. To introduce the session, this is the parallel session 6 on mental health and Asia Pacific, the PARO Declaration on Mental Health in Asia. The session will look at the 25th of the 75th WHO PARO Regional Committee issued a PARO declaration in September 2022. The declaration urges member countries to develop and implement multi-sectoral policies across the life course to address mental health risks and reduce treatment gaps exacerbated by the COVID-19 pandemic, to ensure that mental health services reach all those in need close to where they live without financial hardships. As part of the declaration, member countries agreed to develop country-specific targets to achieve universal primary care-oriented mental health services and mainstream mental health in policy planning, implementation, and evaluation. The PARO Declaration also calls for increased funding for community-based mental health networks and continuous supply of medicines and rehabilitation, including occupational therapy for everyone who needed them, and strengthening of data gathering and reporting, implementation of research and performance monitoring to ensure context-sensitive improvement of mental health systems. The personal and economic distress and disruption caused by the COVID-19 pandemic have widened the gaps in addressing mental health challenges, which includes scarcity of human resources, low investment, stigma, inadequate prevention and promotion programs, paucity of data, and lack of services in primary care settings. The declaration calls for ensuring an effective and comprehensive response to mental health needs by establishing evidence-based and rights-oriented community mental health networks and systematically planning for the deinstitutionalization of care for people with severe mental disorders. Strengthening the capacity of the primary healthcare system is the foundation for the provision of mental health services and progress towards universal health coverage, the health-related sustainable development goals, and the target of the WHO Comprehensive Mental Health Action Plan of 2013 to 2030. Member countries are committed to expanding specialized and non-specialized mental health workforce by identifying new cadres of healthcare personnel who are specifically trained, equipped, and skilled for the delivery of mental health services at the primary care level and work as part of the multidisciplinary teams within the health sector. Community empowerment and active engagement of people with lived experience help reduce stigma and discrimination against people with mental disorders, family members, and caregivers. And so to start this session, would you please welcome our first speaker? Dr. Kanan Subramaniam is a global medical lead for psychiatry of Beatrice, and he's going to talk on mental health in Asia Pacific through the industry perspective. You can have the floor. Or should I have said stage instead?
Thank you for your introduction, Joseph. Good afternoon, everyone. It is a privilege and honor to be here speaking alongside the virtual Dr. Angkor and the legendary Juanita, both of whom are distinguished experts and advocates for mental well-being. I'd like to thank the CEO and organizing committee from IOPO and the local organizers of this conference for the opportunity to speak with you. I'm a clinician, and naturally, I'd like to share with you some science surrounding the issues affecting those with serious mental illness. I'd also like to weave in some storytelling. Next slide, please. Do we call this a technical issue or a human issue? Both. Next slide, please. So I'd like to weave in some storytelling to emphasize what we possibly do to achieve better health outcomes. Let's start with the big picture. This is the data from the Global Burden of Disease collaborators focused on mental health published earlier this year in the Lancet. The heat map shows the burden of disease from mental health conditions worldwide, expressed in disease-adjusted life years or DALYs, which is a measure of overall disease burden expressed as the number of years lost due to ill health, disability, or early death. The hotspots appear to be well defined in the rich nations and some of the poorest nations of the world in Africa. We, the Asia Pacific, seem to be relatively doing much better in this sea of blue, you can see. Looks can be deceiving. The authors of the paper note that the burden estimation methodology for mental disorders used in the study had quite a few limitations. First, despite the considerable amount of new epidemiological data incorporated since their previous global burden of disease study that was published more than a decade ago in 2010, some estimates continued to rely on sparse data sets. High-quality survey data remained scarce for many countries. Second, and really important for the Asia-Pacific region, is that cross-culturally comparable case definitions and case finding for mental disorders has been emphasized. But epidemiological data informing that burden estimate is limited in this respect. Third, estimation of severity distribution was derived from a few studies, mostly from the high-income countries. Imposing these severity distributions to all locations, including low-income countries, is going to significantly underestimate the burden in these countries, particularly those with little or no access to treatment, as is the case in many of the low and middle income countries that we have in the Asia Pacific region. Next, please. The issue of access to treatment is exemplified in this next piece of information on workforce. You can notice, and unfortunately I don't have this red clicker, I should draw one, but the OECD average for the number of nurses working, this is on the right graph, the OECD average of number of nurses working in mental health is about 47 per 100,000 population. The high-income nations in Asia Pacific are well above that, and Australia is leading at 90 per 100,000, almost double, right? The Asia Pacific upper middle income country average is almost only 10% of the OECD average at 4.9. But we might be lulled into thinking Malaysia and Thailand are much better at 7. This is still significantly lower than the OECD average. And of course, the Asia Pacific low and low to middle income average is 1.4. Myanmar, for example, shows 1 nurse per 300,000 population. So we do have a big workforce issue. Next slide, please. So this is further validated by a report from a research commissioned by our colleagues at Janssen Pharmaceuticals, which explores the provision of supporting people with mental illness. Comparison of 15 Asia Pacific countries. The index measures performance across a range of areas relative to integration of mental health into healthcare services. Again, unsurprisingly, Australia and New Zealand lead the indices in the 90s, right? Whereas the lower income countries are below 50. Nowhere, though, do more than half of those affected receive any medical treatment. What the report also considers is that between 2015, when the research was done, and 2020, or 2030 rather, in another 8 years, the economic burden of mental illness has reduced economic growth in India and China by $11 trillion. That's a lot of money. In Australia and New Zealand, knocks about 3.5 and 5% respectively off GDP. And particularly in these times, it's going to be really challenging. And because of the effect of suicide, particularly large problem in South Asia and Japan now, It's not included in these calculations. Real human and financial cost of mental illness is likely to be far worse. Next slide, please. Now, there is a lot of good news, right? There's been a lot of good news for a while. In September 2015, mental health was included in the UN Sustainable Development Goals. This was a historic step. The United Nations acknowledged the burden of disease and mental illness, defined mental health as a priority for global development for the next 15 years. So within Goal 3, which is the health goal, mental health is referred to that 3 times, directly to target, reduce 1/3 premature mortality from all non-communicable diseases through prevention and treatment, and promote mental health and well-being. And is also implicitly stated other universal coverage, as Joseph mentioned before, to achieve universal health coverage, including financial risk protection, etc. With this development agenda, the UN has followed the recommendations of WHO and made the global goals a clear statement for mental health and global development. This is an historic step for mental health, which leaders in global mental health and non-governmental organizations like yourselves have advocated for many years. In 2013, we were privileged, as Beatrice, we were privileged to work with the Asian Pacific Economic Corporation's Digital Mental Health Hub and WONCA, the World Organization of Family Doctors, to advance the dialogue of integrating mental health care and primary care provisions. Then, of course, the bottom picture shows the PARO Declaration earlier this year. So the opportunities are there, and we must embrace them. Next slide, please. Now, the COVID-19 pandemic has not only highlighted its challenges, but also contributed significantly to the burden of disease from mental health conditions. Statistics, data, information, and their analysis can be very confusing, even in the scientific area, and almost alarming at the same time. This first paper by Santamaro and colleagues published in The Lancet early on the pandemic during 2020 estimated the impact of COVID-19 on depression and anxiety is likely to be like a tsunami. They estimated 53 million additional cases of major depressive disorder and 76 million additional cases of anxiety disorders. Wow, quite frightening, I say, and a cataclysmic issue for the already low and stretched health services in our Asia Pacific nations. Next slide, please. However, Maxime Taquet and colleagues, who published a more realistic retrospective analysis of about 2 million patients, The Lancet, in August this year, contended that the outcome probability of mental health conditions as a result of COVID-19 is really going to be no different to those experienced with other respiratory illnesses like the influenza that we get every year. So in the forest plot below, if you can see it, you can see that the hazard ratios for neurological sequelae like cognitive deficits or myoneural junction and muscle disease is higher after COVID. And that is to be expected because that's an organic issue, especially in children. But mood disorders and anxiety disorders remain lower, also in children. Next slide, please. The authors then state an increase in the number of new cases of COVID-19 is likely to lead to an increase in the number of cases of mood and anxiety disorders, but this will be short-lived. And that's very, very important for us to understand. It's important to separate what is natural response to significant stressful situations, like what was experienced during the pandemic, to the actual incidence of major depressive and anxiety disorders. Next slide, please. This is what we found in our own research published in 2021 in collaboration with IOPO and its member organizations, some of you may be here, the International Federation of Pharmacists, and again, WONCA, the World Organization of Family Doctors. We surveyed frontline healthcare workers and patients on the impact of COVID-19 on non-communicable diseases, which are chronic illnesses and include mental health conditions. Healthcare professionals noted persons seeking care for depression and anxiety had increased as a result of the pandemic, and measures put in place to prevent its spread, like lockdowns and social isolation. That was to be expected. Next slide, please. And patients who were surveyed reported loneliness and feeling stressed as having increased. These are natural responses to a situation that impacted heavily on everyone worldwide. Now, I don't wish to say that the natural response should be taken lightly. It is imperative that we mount a preventative effort with services like psychological first aid for those who are affected this way. And this goes back to the topic of this session on the PARO declaration of why we want to address this. So I showed you the results of this collaborative work to emphasize what can be done together. None of us can do this alone. I also wanted to emphasize the importance of including those with lived experience in co-creating any initiative, whether it be research or intervention. Nothing for us without us is an important consideration. So here's another example of working together. IOPO and Beatrice published this model for identifying the touch points in a patient's journey through non-communicable diseases such as mental health conditions. We worked collaboratively with IOPO and persons with lived experience to create this peer-reviewed publication to advance this model, which can be used for co-designing initiatives. Next slide, please. Similarly, we worked with care providers like the World Psychiatric Association, persons with lived experience, and strong advocates for the patient voice like Juanita to develop a multitude of initiatives to create awareness and combat the issue of stigma that prevents people from seeking help. And I think Joseph mentioned that earlier on in his introduction as well. So the BBC Storywords film creates awareness of the issue of stigma that prevented a patient from managing their illness told by the patient himself. The Listen Well podcast that Juanita speaks on again brings the issue of stigma to listeners worldwide. So next slide, please. So these examples that I showed you was to illustrate this waypoint, which I saw on some of us attending this conference. Kob Kun Kla. Thank you.
Thank you very much for that very interesting presentation. It's very educational as well. And now, as Dr. Kanan has said, our next speaker is a legendary speaker from Malaysia. Her name is Anita Abubakar, the founder and president of Mental Illness Awareness and Support Association. And she's going to talk about mental health in Asia Pacific, a follow-up on the Geneva Health Forum of 2022. Friends, please welcome Ms. Anita Abubakar.
Safety comes first. Do you have my slides? I emailed my slides earlier.
The presentation of Dr. Amor Benjapontita, the Director General, Department of Mental Health, Ministry of Public Health in Thailand. And we're going to listen on how Thailand mental health services are organized and the role of Thailand in playing, the role Thailand is playing in the PARO Declaration.
I didn't know they didn't have the slides. I emailed them. Yeah. Do-
Communication, giving a how Thailand mental health services are organized. The role of participating in the PARO Declaration is operated by the try to cover broad and good capabilities. Start with Thailand mental health services. Certain mental health services in Thailand are available, provided by both general care facilities, specialized care hospitals, free of charge and universal health coverage. The inpatient services, we have almost 7,000 supply beds in 34 of 77 provinces in Thailand. Embedded
PSOS, sorry, my eyes.
hospitals and clinics hospitals all over the country. Started as 10.5 beds with those populations. However, we still need more
Okay.
beds
Okay.
to catch up with others. Ratio of supply beds
Do you have it?
compared to potential beds for other those populations. As we realize,
Okay, so I can put it up here. Okay, can I have it?
This is also the time
Oh, but I can reach here. I can reach here.
challenges to prevent the key provisions of the Act include the right protection of persons and mental disorder, categories in society, ensuring full access to the full range of mental health promotion, prevention, treatment, and rehabilitation services without financial barrier. Protecting human dignity and ensuring confidentiality and ethical research. Right protection that assists treatment and rehabilitation for patients in the criminal cases before and after the court ruling, in synchronous with related provision of the criminal procedure code. After giving you the overview of Thailand mental health services, now I'm going to focus more on the latter issue, our role in the PARO Declaration. The first issue, we prioritize the mental health workforce development. Includes the in-service, in-service, and post-service training and employment. In particular, having village health volunteers around the country provide support to the community members on mental health matters too. The next point is pilot and scale up successful models and interventions such as digital technologies and telemedicine to support learning for healthcare workers and to improve access to mental health services at every organization. We realize the digital mental health service will be the next era of mental health service. The balance high-tech untouched service under the concept of value-based healthcare will be a key concept to deploy next normal mental health service. During the last decade, online self-assessment for stress, depression, and suicidal has been fully implemented. Counseling is provided through online and activities of the Ministry of Public Health, the NGOs, and the private sector who combine their efforts to fight mental disorders, in particular to prevent suicide. This is an example of a multi-sectoral and pro-society approach for providing mental health services. Today, mental health service is reaching higher proportion of mental health service in Thailand. Tele-assisted mental health service and tele-psychiatry were implemented in all 20 psychiatric hospitals, providing more than 200,000 visits a year. We deliver telepsychiatry not only in the hospital, but in various non-health settings. Example, in prison, under the Ministry of Justice, in the social spheres, under the Ministry of Social Developmental and Social Security, or even in community. The outcome is promising. Mental health service provision will be very effective with shorter time and lower expenses. In terms of emergency care, we established a helper psychiatric emergency task force with the initiative of integrating of the conventional online, on telephone, and through online digital platform under the collaboration of the Department of Mental Health, parties, and social media influencers who detect and rescue people with suicidal warning signs or suicidal attempts in time. The social media influencer will train to act as a gatekeeper who monitor suicidal signal on digital footprint or transfer and request from their fans received their friends or family members the suicidal signals and send the contact information of those cases to the mental health hotline to provide suicidal rescue online or ask for further support from police. The police in crimes as sexual division can also contact the local police to go for on-scene rescue in time. The on-scene to hospital time increased from 3 to 6 hours conventionally to about 1 hour. From October 2020 to July 2022, we saved more than 399 lives all over the country, which cost around $480 million. Cost to save is important, but not as important as the value of human lives we save and return them to their families. This is another point I want to share. We strengthen community mental health, especially community resilience, the key protective mechanism against the negative impact due to COVID-19 pandemic crisis. We were the leading country to tailor this issue to the WHO Human Act, and it became a new decision with the title Promoting Mental Health Preparedness and Response to Public Health Emergencies. We successfully requested the Director General to provide technical support to member states on community mental health services to boost community resilience and engagement. This could be done by mobilizing social capitals and resources from inside and outside the community to support households affected by the pandemic, especially for the elderly. One quite a few good examples in Thailand of how the community mental health program has evolved and support individuals and communities in boosting their resilience. Some models also support income-generating activities. We call this innovation community-based mental vaccines, providing immunities against devastating psychological impacts of the pandemic. Moreover, in some models, labor volunteers were also mobilized. Volunteers were trained to provide physical and mental care to the elderly who face stress and loneliness. Ladies and gentlemen, what I have mentioned is some of the world talents claim the power declaration to accomplish mental health system development in various aspects. We all know that there are a lot more to overcome. We still keep moving to encourage all health and non-health sectors to aware of the importance of mental well-being because there is no health without mental health. Thank you. Thank you very much.
Thank you very much. So once again,
Yeah.
that's all on companies.
Thank you so much. It would suck if my presentation wasn't good, right? So anyway, thank you so much to the technical team. Thank you to Joseph as our moderator today, Dr. Amorin. Dr. Aporn, Dr. Kanan, thank you so much. And also congratulations to IAPO and also the local partners in Thailand. Sawadika, Kapkunka. Thank you very much. Congratulations for bringing forth the 4th Asia Pacific Asians Congress. So I will touch a little bit about mental health in Asia Pacific, and also specifically on Malaysia. And Dr. Kanan gave us, a really nice picture on the global mental health. So hopefully providing some insights on Malaysia, a little bit more so that we all have a little bit more of understanding on Malaysia and also Asia Pac. Okay, just give me a second here. So we spoke a little bit about the PARO declaration. So I will touch a little bit on that and how it relates to the work that NIASA, the organization that I formed in 2016 with obviously a lot of my friends, persons with lived experience of a mental health condition. So I myself am a person with a mental health condition. And I stand here really representing many of the voices, those that are unable to speak for themselves, those that are silenced due to stigma, silenced due to discrimination, and a lot of the injustices that happen, human rights violations across the globe, really. So several months ago, just to give a little bit of context, WHO urged countries across the globe to increase investments in mental health. And this is one of the things that we've been seeing happening in Malaysia, specifically the country where I come from. And we're truly happy with the progress, although a little late, but of course, nothing better late than never, we say. And not only is imperative that we prioritize mental health, invest in mental health, but also without enough financial resources, obviously mental health systems struggle to provide adequate support to meet people's needs. However, the problems of mental health provision cannot be, addressed by simply increasing resource. We must transform the way mental health care and support are conceived and provided. So we see recently, or several months ago, WHO came out with the report, World Health Report on transforming mental health for all, and also, the Lancet Commission report on ending stigma and discrimination. And, being a person with lived experience, it was really heartwarming to see this report come out, not only because it touches on stigma and discrimination, but because it was co-produced and co-led by people with mental health conditions. So that is indeed a progress, and hopefully that transformation happens. So going into my presentation today, I was told I have 10 minutes. Obviously, I'm not going to be able to finish this in 10 minutes, but I have two strategies, talking fast and skipping some slides, so maybe I'll do that. So just giving it a little bit of context about Malaysia. So Malaysia is a middle high-income country with a population about 32.6 million, and majority of the people live in the urban areas, with the majority of the population are indigenous Malays. So I am a Malay myself, which is about 70% of the population. And mental health disorders, sorry for the typo, prevalence rate in rural region is 43%, in the capital city is 40%. So this is really in line with obviously the risk factors where, if you are in maybe more of the low middle income countries or the rural areas, you have consistent stress, also you are more prone, more susceptible to a mental health issue. And of course, increased prevalence of mental health issues due to rapid cultural and lifestyle changes, urbanization, globalization. Of course, it increases stress levels. And when we're looking at Malaysia, 29.2% of everyone, adults really ages 16 years old and above, struggling with a mental health issue. And we're looking at possible causes of, obviously, with the pandemic hit, financial difficulties, uncertainties. A lot of people have lost jobs, reduction of income. Today, they find themselves in a huge pile of debt, not being able to pay that debt, not being able to sustain their livelihood. And of course, being cut off from effective social, coping mechanisms, social support, poor coping skills, and poor social support to begin with. So obviously, with the pandemic, exacerbated a lot of the mental struggles. An effective treatment is actually available, but Malaysians may not seek help due to, how prevalent stigma is. You feel, truly ashamed, truly afraid to seek for that help, because then the label, the judgment comes in. The conversation of employment, as an example, stops the moment that you reveal that you have a mental health condition. So we bring it to the context of economic analysis. We're looking at about 4.46 billion in Malaysian ringgit, in 2018. So this projection was done before the pandemic hit. So obviously today the amount is higher. And the impact of the pandemic, I think we all know this, just to highlight, increase in poverty. Around 580,000 households, which were previously in the middle income group, slipped into the bottom 40 group. And this translates to about 20% of the M40 households, adding to the absolute poverty rate, which is rising to 8.4%. And unfortunately, 79% of Malaysians who struggle from depression are from the bottom 40 group. And if we look at the mental system in Malaysia, what are the local assets? What are we currently offering? So we have our psychiatric hospitals. These are what we usually, or previously known as mental institutions. We have 4 big psychiatric hospitals still standing in Malaysia, although one has gone through a transformation where it has implemented a no restraint policy since 2014. And we also have psychiatric units within general hospitals, about 64 hospitals, so about 935 beds. Although the action moving forward by the ministry is actually to decrease the number of beds in psychiatric hospitals, but of course being a patient group that we advocate for the closure of institutions for anything in relation to institutionalization, and adding more beds in psychiatric units within general hospitals. And of course we also have outpatient, where in Malaysia currently we have about 400 family medicine specialists that are able to assess and also diagnose individuals with mental health conditions. So if we look at the fragmentation of the Malaysian mental health system, we're looking at, you have the psychiatric teams, where in the psychiatric units within general hospitals, they manage 90% of all new patients, 83% of all follow-ups, and they manage 75% of all admissions. And if we look at the public health side, looking at the primary care network, which what we should be doing currently is leveraging on the primary care network, which is, I think, progressively happening, because we see now that the ministry is aggressively training GPs to really understand mental health, because a lot of times when people visit or go and see their GP in the community, that they go home empty-handed. And at the primary care network, we're only looking at about 0.07 of cases seen at clinics classified as mental health cases, and 0.5% of patients per year are referred from specialist care back to primary care. Institutionalization, this is something really, something that is really close to my heart. And the reason for, my friends, my peers being, in institutions in Malaysia and, in Asia is obviously first inabilities of families, loved ones to care for them, lack of knowledge, poor mental health literacy, feel helpless, people getting the help late, so it becomes severe, and then, family members, loved ones don't know how to care for them. Lack of community support services, obviously, information gap, inadequate access to transportation, limited financial resources, and of course, non-appropriate care in the home environment. And social stigma and fear of harassment or abuse are also factors in decisions to place them in institutions. And if we refer to the Mental Health Act in Malaysia, we're looking at involuntary admissions are also possible, and hospitals have the power to detain and admit psychiatric patients without their consent. So this is definitely coercion, and this is one of the things that, at MIASA, the organization that I'm with, that we advocate, for zero coercion. And beginning of last year, we actually carried out a campaign called Zero Coercion, really trying to provide these information to the public, and also encouraging our peers that have gone through whatever coercive practices and treatments it may be to speak about it, so that we can all understand the harm of it, and how there's no evidence to back whether going through a coercive, whatever coercion that happens helps to improve recovery outcomes. In contrary, it's truly harmful. And so when we talk about the gaps, obviously there are a lot of gaps. We also want to, talk about solutions. How do we move forward? So really quickly, some of the gaps that I would like to touch, in addition to what I just mentioned, is of course lack of a sustainable model in the community. And a lot of times when we don't have a sustainable model, even though, individuals have gone through that recovery process, when they come into the community, they're not able to get a job, they're not able to get a roof on top of their head, and then they relapse, or their episodes reoccur, and then they fall through the cracks of the system again. And this is how we reinforce the stigma. Then people say, look, Anita, people with mental health condition can't recover. And of course, again, lack of investment and prioritization in Malaysia alone. We're looking at about only investing about 1.3% in mental health, where that budget 1% is given to mental health, and 66% is actually allocated to them for mental institutions. So people in the community, 99% that struggle with anxiety, depression, personality disorders, addictions, are underserved and undertreated. And of course, lack of peer engagement as well. And one of the big things at MIASA, what we do is we do a lot of outreach programs, specifically my friends from the people that are homeless, and the aftercare of homeless individuals with mental health disorders. This is also another gap that we're looking at. So a lot of them are given the treatment, and then when they leave the hospitals or the rehab centers, where do they go? Because there's, again, not a place for them. Even shelter homes in Malaysia do not accept people with mental health conditions. The reason being is they don't have resources, they don't know how to care for them, and so it's so straightforward. If you have a mental health condition, we do not accept you, full stop, that is it. It's really unfortunate and really sad. And Malaysia hasn't ratified Articles 15 and 18 of UNCRPD, and also the optional protocol, and even our Mental Health Act does not contain the human rights language. And it also didn't have peers involved in the making of the Mental Health Act. So when we're looking at addressing these issues, if you look at the slide that I have right here, so we're looking at homeless folks unwell, go to the hospital for treatment, they're stable, they get discharged, and then they go back to the community. If there's nothing there, then they go back, and this is when chronic homelessness happens. And so what we're really hoping, and what we've been advocating for, is for hospitals, the ministries, to work with shelter homes, nursing homes, community centers on continuity of care for peers on site, task shift to the NGOs, empower the community to assist, because we can do a lot. We are the closest people to the people that are struggling on the ground. And of course, social welfare departments, respective agencies to provide work, provide support and accommodation, and provide incentive to employers to take in people with mental health conditions. And ending abusive practices obviously is possible. We're looking at, again, for my hospital, as I mentioned earlier, they've done a lot of good practices that have been really fruitful, where they do one-to-one nursing for those that present aggressive behaviors and struggling with suicidal thoughts, ideation, or even contemplation of suicide. And patients are discharged if they are consistent in their treatments, medication, and they are in stable condition. And then they go home, be amongst their families, social support system, and then they go through an acute home care team that are able to visit them 2 to 3 times a day, also an assertive program where they're able to get visitation 2 to 3 times a week from a multidisciplinary team from the hospitals. So just as a follow-up from the Geneva Health Forum, which I co-led with Dr. Kawal, this is a brief overview on the current situation where we'll touch a little bit on Indonesia, Philippines, Hong Kong, and Taiwan. And this is the comparison table. So if you look at the population, obviously Indonesia, those of you that are very familiar with Indonesia, Indonesia has a huge population, 276 million people. And we're looking at a very unique country where there's hundreds of islands, everyone is really spread out. But what is interesting about this comparison table is if you look at the comparison, Hong Kong, 7.4 million prevalence of mental health issues, really high, 61%. And Taiwan, second smallest population in these countries that we presented, 23.8% in terms of mental health issues. Malaysia, as I mentioned earlier, 29%. And Taiwan having the highest number of psychiatrists per 100,000 population, which is about 7.25. So you will have to wait about 92,000 people, then only you'll get to see a psychiatrist. So you see the limitation in human resource. And psychiatric units within general hospitals, obviously Indonesia has more, but if you look at percentage, it's actually quite low. And the mental health budget, we have Philippines, the highest at 5%, Indonesia 2.89%, and Taiwan 2.55%, which is slightly above the global median of about 2.1% at the moment. So obviously we've got to do more, invest and prioritize in mental health, but also transforming, again, mental health for all. So just a few things that I wanted to touch here is, in Hong Kong alone, we're looking at 61% of people having mental health issues. We're also looking at in the workplace. Hong Kong actually has the longest work hours per week. It's about 51.1 hours. And so mental health issues are obviously very prevalent. About 73% of the population, they don't really know that workplaces do provide interventions. So this is how much of non-communication that is happening within the workplaces. And more than 50% of people in the workplaces have said that they've seen how it's so negative when you assert your identity, when you disclose that you are indeed struggling with the mental health issues. Employees really don't do much. So this is the struggle of Hong Kong at the moment. And we're looking at Philippines. So they just in 2018 have the first Mental Health Act legislation, where it is of human rights based approach, or human rights language, where they protect their patients, they have their rights, they don't practice coercive treatments as much as possible, guided by the Mental Health Act. And also Indonesia, I think when we talk about Indonesia, we've heard, or many of us within the mental health space know about the Human Rights Watch report that was out, I think about 4 or 5 years ago in PASO, where Indonesia is very widespread, the practice of confining and restraining people with mental health condition as a remedy. And although the government had outlawed PASO in 1977, it's still very much spread across. And again, it's because of misinformation, not able to access treatments, not able to get information. So mental health literacy is very poor, psychoeducation is also very poor. So PASO continues to be one of the treatments that they implement to enforce safety and protection against dangerous behavior. And in Taiwan, what has happened is in 2007, they amended their mental health acts and they put patients and their families first. And so with that, people with lived experience are, are being guided or involved in that process. So this is one of the progressive moves that has been done by Taiwan. Okay, so now going into MIASA really quickly. So MIASA is the Mental Illness Awareness and Support Association. The majority of us are people with lived experience, either a person with a condition or a family, a caregiver, and the majority, and the balance are mental health advocates, of course. So what we do is we continue to develop, to expand, and also strengthen community support services, and also fight for peers' rights and autonomy, providing liberty, supported decision making, and also providing livelihood, both relief support and also livelihood support. And so our vision is obviously fighting stigma and discrimination. These are some of the resolutions that was agreed upon actually during the Malaysia stakeholder meeting that we hosted in 2019 with TCI Global, Transforming Communities for the Inclusion of People with Psychosocial Disability, where all the stakeholders agreed upon these resolutions, so providing support, accommodation, and housing rights, employment rights, healthcare rights, and of course quality healthcare, closing down mental institutions. And at MIASA, one of the things that came about via this pandemic, why the private sectors came in, funded us, and we were able to finally launch our 24/7 crisis helpline. We've had this helpline for 4 years now, but it was never 24/7. It was 12 hours before. But now we're able to have it 24/7. We've got our crisis team nationwide, increased training, consistent training, and also recently with collaboration with Mental, formerly known as Facebook, we collaborated and launched the MIASA's chatbot via WhatsApp. So just to give you a little bit of insights, those that are not familiar with Malaysia, we're looking at about, this year alone, about 27,000 people. Obviously, there's about a discrepancy, about 10 to 15% in terms of collection of data, where we're looking about 27,000 people reaching out for the help. So obviously, being an NGO like MIASA, we are overburdened, we're overstretched, and we have been that way since the pandemic hit. It's a good thing. I mean, one of the silver linings is we're now able to normalize this discussion so much. So a lot of people feel more encouraged to reach out for the help. But in the community, we're overburdened, we're overstretched, like how, the health systems were overburdened and overstretched because of COVID, we're overburdened and overstretched because of mental health. And what we've done is, in terms of awareness and advocacy works, a lot of collaboration, a lot of awareness via a lot of talk shows, television, radio, research projects, roundtable discussions in Malaysia and across the globe as well. We talk to the ministry, we work together with the Ministry of Health, Ministry of Youth and Sports, and various stakeholders as much as possible to bring alive the voices of people with lived experience. So as much as possible, the services, the support services that we offer at MIASA, it's a one-stop center. We strive to provide and expand these services so that nobody goes home empty-handed. There's always something for everyone on the menu. And we also launched our very first peer-run crisis management center and also activity center. So all the programs, if you come to Malaysia, come to MIASA, and you will see how all our programs, activities are all run by people with lived experience. And of course, when we talk about relief support, we provide circle time, a support group session, which is peer support is evidence-based, circle of care, WhatsApp support groups, spiritual therapy, a lot of art-based therapy, dance classes, speech and drama. We also do home visits. We have counseling services, mental health assessment, counseling, psychological services, etc. And we also support our peers in terms of livelihood support. So we conduct supported employment programs and job placement, supported volunteering, and we also promote peers in their business ventures, and we promote that on our social media as well. So just the last bit on the PARO declaration. These are some of the points that we have highlighted, and just to relate it back to Malaysia and the work that we do, ensuring universal access and reducing existing inequities related to mental health care. So we provide essential services at no cost to the B40 group. So the bottom 40 of Malaysians, if they come to MIASA, it is at no cost to them, although we're not financially independent. So the middle income groups, the higher income group earners, they pay for the bottom 40. So that's how we're able to sustain the work that we do. And also, we do a lot of outreach services to our homeless folks and reorienting and strengthening mental health care towards primary health systems rather than secondary care exclusively. And of course, because of primary care network in Malaysia, we've got about 1,001 health clinics. We have 6,000 to 7,000 GPs, and we must leverage on the primary care network. And we need to scale up the care in the community. So we empower the GPs, the family medicine specialists, the healthcare workers, because not everyone needs obviously a intensive clinical intervention, right? So you can just go in, do an assessment, and the doctors can teach you effective coping mechanisms, even quick wins like deep breathing exercises or relaxation techniques, and promote work-life balance, sleeping well, eating well, exercising, those kind of things that maybe sometimes we neglect. We know this, but we neglect, and with all the factors and contributing factors that have increased by this pandemic, it's really, really crucial for self-care. And committing to ensure an effective and comprehensive response to mental health needs. And of course, systematically plan the process of deinstitutionalization of care. And I've been very much involved in discussions surrounding DI. And I was also interested in 2019, I presented on no restraint. I presented on what my hospital has done to finally implement a no restraint policy in Malaysia, and also the campaign that we've been running for 2 years now on zero coercion. And of course, combating stigma and discrimination through community empowerment and active engagement with people with lived experience. And so we carry out a lot of campaigns, day in and day out, and obviously being led by people with lived experience, because we are experts of our condition. We live it, every single day in and day out. And lastly, working across sectors to ensure a comprehensive mental health response, including ensuring adequate investment and lobbying for more equitable mental health policy. So we've forged a lot of partnerships, alliances across Malaysia, globally as well, in both government as well as non-government sectors. And again, we work closely with the ministry. It has to be multi-sectoral, has to be, multi-cross stakeholders, and this is what we strive to do until today. So that is all. Thank you so much, everyone, for your kind attention. I hope that was helpful. Thank you.
That was amazing. You should be declared national hero in Malaysia. Okay, in the interest of time, we can only accommodate the 1 or 2 questions from the audience. Is there any questions that you wanted to ask our speakers? If there is none, I would like to ask Dr. Kanania very briefly. If you'll be given a chance to talk to the state leaders on those who are willing to support the PARO declaration, what steps do you want them to take?
I don't really have to say much, because Anita just described all the stuff that you can actually do. If you tease what Anita mentioned just now, there were 3 things that really came to mind for me. One is, don't give money to the institutions, please. Because it costs more, it doesn't actually help. Just to give you a story, while I came to Thailand, in New Zealand, there's a story erupting. We spent $1.9 billion since 2018, and the outcomes were nothing for mental health business, right? So, this is a country that's already up there, as you saw, about access to care, etc. But 1.9 billion did not deliver the outcomes that people were expecting. So I think what Anita said is really, really important. To the minister, I'd say enough to the institutions, give it to the peers, give it to the caregivers, because people who care for people with lived experience need to be supported. And that is so important. And you don't have to give much because you can spend enough to make sure that they are equipped to deal with this issue. I think that's the most fundamental importance of it.
Thank you very much. I think that was a great self-explanatory answer. Anita, last question. As working for an organization, an NGO, what's your biggest challenge that you have to hurdle? In terms of what you got from it?
Okay, I think it has changed because when we first started, I think it was the resistance, especially in Malaysia, people didn't really understand why are people with lived experience coming out advocating this cause, we weren't treated equally. So that resistance really happened majority amongst the mental health professionals when we began. And then later on, what happened was I then, leading this organization with my team, realized that the action would finally speak for itself. So eventually that was what happened. So now we're widely accepted. And I think we came, the time that we came, it was really timely because that was when all these different advocacy groups came up. So I think it's a huge collective effort globally. So this has really eased that process. So that was in the beginning. Then later on, obviously, it was the funding. Funding is always a challenge, right? But now, because we've done so much that people want to fund the money, because at the end of the day, people want results, right? You want to see the outcomes. Okay, we give you a grant. Recently, we received a grant of 1.3 million. We're very transparent about it. So we received the grant, but then you have all these outcomes that you have to achieve. And so people want to see this, organizations want to see this, funders want to see this. So that was the next huge challenge, I guess. And then now is more of getting everyone to work together. So it's that coordination, because it's not just mental health NGOs and social enterprises and civil society, but we really need, like what Dr. Khanat mentioned earlier, I think you mentioned that, nothing about us without us. So we need the whole entire persons with disability groups, all the DPOs to come together. We don't want to be working in silos. And obviously, nobody wants to work in silos, but sometimes we don't really know how to coordinate ourselves. Even the ministry doesn't do a good job in coordination. So I think this is the other challenge that all of us need to come together, unite, and that is how we'll be able to push for better policies amendments of the Mental Health Act. Imagine Malaysia's Mental Health Act came about in 2001. It has never been amended until today. Doesn't contain the human rights language. You can coerce people into doing whatever. And I think this needs to change. And with many advocate groups coming to birth in Malaysia, Malaysia today has 52 NGOs nationwide. So I believe together with the persons with disability groups that we can push for more.
Thank you very much. How about a big round of applause to our wonderful speakers today. At this point, I have nothing more to say, but to thank our speakers, Dr. Ampoy Benjamontica, Dr. Ganan Subramanian, and Ms. Anita Abubakar. Thank you very much.
Thank you. Thank you, Joseph. Thank you.
Thank you very much. Before we leave the finish, shall we have a group picture, please?
Yes.
Yeah.